So I'll start with introducing myself. My name is Bridget Montgomery. I am a licensed clinical social worker. I am a private group practice owner, and I am an educator, consultant, and an advocate for parents with children who have special needs. I do a little bit of everything as well. Some would say, eclectic. We'll use that word. However, if I was to narrow in a focus and talk about what I do specialize in, my area of expertise is trauma and sex offending. So that's what I specialize in. So today, what we're really going to focus on in this particular group, and I don't know if we're going to shift. We might shift. It just depends on the flow of people coming in and out. But what we want to focus on today in today's group is suicide. Hi, welcome. Okay. I think we have some people coming in taking pictures and maybe some video too. So what we'll be focusing on in this particular group, as I was saying, is suicide ideation, suicide attempt, and actual suicide. Right? It is a much needed topic. It is something that we all, regardless of what area or focus you have, is something that you should be aware of. Something that you should know and understand how to spot, follow up, and refer or safety plan. There's the word I was looking for, right? So I don't know if you've been paying attention in the recent news, what's happening. A lot of babies under the age of 12 is committing suicide. I don't quite understand that. I don't understand how such a young child could get it up in their mind or fathom the idea of taking their life. And I guess, sometimes what happens is that we go through something and the pain is so immense and so intense that we just don't know how to handle it. And what would you do if you were faced with someone that came to you and was sharing something that at the depth of their soul they just didn't know how to handle, and they felt like there was no option for them but to leave this earth, to end it all? What would you do and how would you handle that? So that's kind of like what we're going to talk about a little bit about today. And the way we're going to do that is via a case study. Okay, so what I really love about the Clinician Think Tank is each month that we come together, we try something different and we do something different. I don't know how many times you've experienced. I don't know how many times you came out. Oh, you said this your first time, right? But each time we try to do something different. But what we mostly try to do is make sure that it's interactive. Okay, so everybody participate. We're all here to learn and glean from one another. We're all here to take away something and give and share whatever you have to offer. Share it. Never think that you don't have anything to offer. Labels are labels are labels are labels. Letters are letters are letters are letters. But your experience in and of itself could speak a whole lot. Okay, so share that with us. Help us understand what you know. We talk about it, we dialogue, we learn from each other. And if we don't know something, there's always research. We always got something, some kind of homework that we can follow up on and try to get that information. And then next time we come together, we can share that, or even share it via social media, the way emails and different ways that we can contact one another. Any questions? All right, cool. So I am going to. It's a long case study. And that's okay. Dr. Tina felt as though, I can read that. No. So we can do it one of two ways. I can read it myself, or we can read it together. We'll just go around, take a paragraph, and that way make it more enjoyable. Just read slowly, clearly, so we all can understand. We can just follow along. If you want to start. Okay. I'm sorry. I am terrible with names. Please, please, please forgive me if I can't remember your name. But I'm going to do my best. Tell me your name.
Dara.
Dara?
Yes.
All right.
Okay. The young lady, age 30, carefully dressed in black, which comes into the hall with short, shuffling steps, leaning on the nurse, and sinks into the chair as if exhausted. Give you the impression that he is ill. Well, probably she is ill. She is of slender build, her features are pale and rather painfully drawn, and her eyes are cast down. Her small manicured fingers play nervously with a handkerchief. The patient answers the questions addressed to her in a low, tired voice without looking up, and we find that she is quite clear about time, place, and her surroundings. After a few minutes, her eyes suddenly become convulsively shut. Her head sinks forward, and she seems to have fallen into a deep sleep. Her arms have grown quite limp and fall down as if palsied when you try to lift them. She has ceased to answer, and if you try to raise her eyelids, her eyes suddenly rotate upwards. Needle pricks only produce a slight shudder, but sprinkling with cold water is followed by a deep sigh. The patient starts up, opens her eyes, looks around with surprise, and gradually comes to herself. She says that she just had one of her sleeping attacks, from which she has suffered from for 7 years. They come on quite irregularly, often many in one day, and last from a few minutes to an hour.
Okay. So I hope you guys were able to identify some symptomology in that first paragraph. You know what I mean by everybody know what I mean by symptomology. Okay, so there's quite a few. So let's keep that in mind. Miss Pat.
Concerning the history of her life, the patient tells us that she was educated in convent schools, passed the examination for teachers. As a young girl, she inhaled a great deal
Yeah.
of chloroform, which she was able to get secretly for toothache. She also suffered from headaches until they were relieved by the removal of growths from the nose. She very readily became delirious in feverish illnesses. 13 years ago, she took a place as governess in Holland, but soon began to become ill, and she passed the last 7 years in different hospitals, except for a short interval when she was in a situation in Moravia. It would appear from the statement that her relations and doctors that the patient has suffered from the most varied ailments and been through the most remarkable courses of treatment. For violent abdominal pains and disturbances of menstruation, ascribed to stenosis of the cervical canal and retroflexion of the uterus, recourse was, I'm sorry, y'all. Recourse was had 5 years ago to the incision of the wedge supposed to cause the obstruction and the introduction of pessary is it. At a later period, loss of voice and contraction of the right forearm and the left thigh set in and were treated with massage electricity, bandaging and stretching under the anesthetic. Heart oppression and spasmodic breathing also appeared, which quickly passing disblements of various sets of muscles, disturbances, and urination, diarrhea, and unpleasant sensations, now in one and now in another part of the body, but particularly headaches. Extraordinarily strong and sudden changes of mood were observed at the same time, with introspection and complaints of want of consideration in those about her and in her relations, although the latter had made the greatest sacrifices. Bryn baths, Russian baths, pine needles baths, electricity, country air, summer resorts, and finally residence on the Riviera. Everything watched, tried, generally with only a brief improvement or with none at all.
Okay.
The immediate cause of the patient being brought to the hospital was the increase in the sleeping attacks 2 years ago. They came on at latest even when the patient was standing and might continue for an hour. The patient did not fall down, but simply leave to get something. The attacks continued in the hospital, and spasmodic breathing was also observed, which could be influenced by suggestion. After spending 8 months here, the patient went away at first to her sister's, but after a few months, she had been taken to another asylum where she stayed about a year, and then after a short time spent with her family, came back to us. During her present residence here, so-called great attacks have appeared in addition to her previous troubles. We will try to produce such an attack by pressure on a very sensitive left ovarian region. After 1 or 2 minutes of moderately strong pressure, during which the patient shows sharp pain, her expression answers. She throws herself to and fro with her "I shit" and screams to as loudly, generally in French, not to touch her. "You must not do anything to me. You handle cockun. Cockun?" She cries
Coach
Coach, okay. She cries for help, pushes with her hands, and twists herself as if she were trying to escape from a sexual assault. Wherever she is touched, the excitement increases. Her whole body is strongly bent backwards. Suddenly, the picture changes, and the patient begs piteously not to be cursed, and laments and sobs aloud. This condition, too, is very soon put an end to by sprinkling with cold water. The patient shudders, wakes with a deep sigh, and looks fixed around, only making a tired, senseless impression. She cannot explain what has happened.
All right. You want to read, or I can finish it up? It's...
I thought he was asleep. All right. The physical examination of the patient shows no particular disturbance at present, except the abnormalities already mentioned. There is only a few marked weakness, in consequence of which she often keeps to her bed or lies about, or her movements are limp and feeble, but there is no actual disablement anywhere. She often sleeps very badly. At times she wanders about in the night, wakes the nurses, and sends for the doctor. Her appetite is very poor, but she has a habit of nibbling between her meals at all kinds of cakes, fruit, and jam, which are set at her request by her relations.
With her growing expert in us and illness, the emotional sympathies of the patient are more and more confined to the selfish for the ring of her own wishes. She tries ruthlessly to extort the most careful attention from those around her, obliges the doctor to occupy himself with her day or at night on the slightest occasion, is extremely sensitive to any supposed neglect, is jealous if preference is showing to other patients, and tries to make the attendant give in to her by her complaints, accusations, and temper outbursts. The sacrifices made by others, more especially by her family, are regarded as matter of course, and her occasional prodigality thanks only to serve to pave the way for new demands. To secure the sympathy of those around her, she has recourse to more and more forcible descriptions of her physical and mental torment, histrionic extravagations of her text, and effective elucidation of her personal character. She calls herself the abandoned, the outcast, mysterious hints, makes confession of horrible, delightful experiences or feelings, which she confide only to be discreet bosom of her very best friend, the doctor.
Oh, wow. That's a lot going on, the suffering lady. That's why we titled it The Suffering Lady, huh? It's a lot going on. would you do with a woman that comes into your office like that, displaying, going through, sharing? I mean, there's a lot. There's a lot going on there, right?
Yeah.
30-year-old, distressed, right? Slender build, features are pale, painfully drawn, eyes are cast down. Somebody's eyes are cast down. That suggests what?
Depression.
You say depression? Sleepy tiredness? Cast down. Shy.
Could be a multitude of things, but yeah, some
Right.
type of depression.
Insecure. Right? So there's a lot of different things you could get from cast down eyes. You know, and some cultures,
Right.
Yeah,
Yeah.
it's true.
It's true.
it's a sign of
Yes.
respect. We're not going to make eye contact. So we can never just really assume what. So you got to pay attention to the whole
Right.
package, right? So cast down eyes. Her small manicured fingers play nervously with a handkerchief. Right, so maybe maybe she's a little uncomfortable or something. Yeah. The patient answered the question.
Scared of herself.
Addressed to her in a low, tired voice without looking up. We find that she's quite clear about time, place, and her surroundings. So it looks like status, a mental status, time, place, surrounding. Seems like she's aware of that. After a few minutes, her eyes suddenly become convulsively shut. Her head sinks forward, and she seems to have fallen into a deep sleep. That sounds like a little bit of heroin or something, right? One minute she there, next minute she's just out. That's what that sounds like to me. You wanted to say something?
No,
No, I was just agreeing.
Agreeing,
Or
yeah.
her meds were too
Or her
strong.
meds were too strong, right? That's a good point. Her meds might have been too strong. Her arms have grown quite limp and fall down as like if they were palsy, like cerebral palsy, I guess. When you try to lift them, so you know that cerebral palsy kind of heavy. I got the sense of heaviness. Yeah. She has ceased to answer, and if you tried to raise her eyelids, her eyes suddenly rotate upwards, so it's kind of like rolling up in her head. Needle pricks only produce a slight shudder, but sprinkling with cold water is followed by a deep sigh. The patient starts up, open her eyes, look around with surprise, and gradually come to herself. She says that she just has one of her sleeping attacks from which she has suffered for 7 years. Oh, there you have it. Sleeping attack? Okay. They come on quite irregularly, often many in one day, and last a few minutes to a half hour. You ever deal with somebody with a sleep disorder and out of nowhere?
They just
I don't
fall
mean to
asleep.
laugh, but like I had an uncle like that. Like study check, Uncle Gary. Dude. I wasn't asleep. Man, you were over there. You were gone, right? Concerning the history of her life, the patient tells us that she was educated in a convent school, passed the exams for a teacher. As a young girl, she took a great deal of chloroform, which was able to get. She was able to get it secretly. Oh, somebody was handing that over for a toothache. All right, so we got a sleeping disorder. Sounds like she's dealing with some pain here in her tooth. Sounds like. She often suffered from headaches until they were relieved by the removal of growths from the nose. Ooh. Ouch. So she has some ingrown stuff going on. Those ingrown hairs can be quite painful. Ouch. She readily became delirious in a feverish illness. All right. Okay. Can y'all see that?
Yes.
13 years ago, she took a place as a governess. Soon became ill, passed the last 7 years in different hospitals, except for a short interval where she was in a situation in Moravia. So it seemed like she went from here to here to here to here. You know, so this is a really sick woman sounds like from the sleeping disorder to, suffering from these massive headaches, to having things going on here. It would appear from the statement of a relation doctor that the patient suffered from most varied ailments and been through the most remarkable course of treatment, from violent abdominal pain and disturbances of menstruation, stenosis of the cervical, retroflexion of the uterus, recourse. The recourse was 5 years ago to, they had an excision, looks like. At a later period, she lost her voice. Forearm, heart oppression, spasmic breathing, and appeared quickly passing dis-elements of various sets of muscle disturbances, urination, diarrhea, unpleasant sensation now in one and now in another part of the body, but particularly have headaches. So she's not able to handle her bowel movements, it seems like. Still with headaches. A lot of somatic issues, a lot of physical ailments. But I'm not getting any sense of where it's coming from. I'm hearing all of her symptoms. Did anybody yet find any?
I was thinking she was taking that chloroform and it was given secretly, so it's probably not from a doctor.
Right.
So maybe it's like street drugs.
Right.
And that could have like, chemical imbalance or something.
Well, yeah.
To know how much she was taking.
Right.
So she was taking something illicit off the street that was not prescribed. So it could have added to some of the symptomologies that she's experiencing.
Some
But
interference with her medication.
Right.
did we find any medication?
Well,
Yeah, did it say that she was on any medication? I just hear like a lot of physical problems going to from doctor to doctor to doctor and coming up with the headaches, the dizziness, the tummy aches and different things like that. Ever stress yourself out so much to the point of a bad tummy ache, or ever dealt with a kid who will constantly complain about a belly ache and they don't really understand why, but they're stressed? When you deal with trauma, you get a lot of children with a lot of belly problems.
Anxiety.
Their bowels are all messy. Can't hold it together right. And they really don't understand why. You testing, you're not really coming up with any real medical diagnosis. So I'm still hearing symptoms, but I'm still not getting anything. Anybody else getting anything yet?
Well, what I pretty much got out of it was, and it's just speculation, that chloroform is not a street drug, first of all. So I would think that her doctor, her parents were either doctors or dentists or something that had access to it. So she would have access to it secretly because it was in their office or whatever. You know what I mean? Just in my... But the last part that talked about the doctor being her best friend, that makes it for being psychosomatic so that she could be close to the doctor. So a lot of those symptoms are for the doctor to be her best friend, basically. That's what I said.
What'd you say?
I said to give her the attention that she
Okay.
Right.
I like it.
Yeah.
All right. Yeah. All right. Anybody? Anything else? I mean, when you're dealing with those types of symptoms, it's just a 2-page full
a
of
number of
symptoms. Symptoms related to what? Where is it coming from? What's going on? And sometimes we can do what? We can
Think it.
Think.
It
Think
says
it.
that it increased with suggestion.
What page are you on? The second page?
Second page. Influenced by suggestion.
Can you read that so we can try to
Oh,
find
I'm
it?
sorry. The attacks continued in the hospital, and spasmodic breathing was also observed, which could be influenced by suggestion.
What do you think that influenced by suggestion?
Well, that tells me it may not necessarily be so, but she was attached to the doctor, so now she's getting the attention.
Right.
So she's going to go for the gold.
Right. Remember Munchausen? Remember that?
There's a
Probably
commercial
not.
on that.
Probably not. The boo-boos probably don't. Right?
There was a commercial on recently.
About Munchausen?
No,
Oh.
about this lady. The daughter. She's making the daughter seem like she's sick.
Yeah.
Yeah.
And that's like Munchausen to me.
Mhm.
And the daughter says to her, I'm not sick. You just want attention from all these people.
All these people.
You know what I mean? And she's
Causing
killing
all
the
these
daughter.
ailments to get the
Right.
attention. So when you start speaking about the attention, sometimes it's attention-seeking behavior, and we create these problems or whatever for the attention. And sometimes there's really no known diagnosis, and it's just somatic. You heard that term before, right? Right. And we're familiar with that means. What that means? With what that means.
And it's just like what they're thinking, what they think they
Thinking about.
what you're thinking of, like what they want it to be. what
Is the
they
pain
want-
real?
No, it's not.
No.
It's all in their
None of
mind.
it
It's
is
mental.
real. It's just in our
Yeah.
mind.
Is it real? Is the pain real?
It could be.
Yeah.
Possibly the physical stuff could be, but a lot of that can be both. It's a combination.
But
That's why they came up with NOS.
But also, prior to the extent for what she expressed, it could, maybe it's not as.
So they're actually experiencing the pain.
Yeah.
They're feeling the pain, and they really believe the pain exists, but there's really no known cause or nothing that's connecting the pain to okay, this is where the pain is coming from, or this is quite possibly the disease that is behind what you're experiencing. A lot of times, so I literally right now as we speak, I have 2 clients that I've been treating for well over 6 years that have somatic pain, in and out the hospital at least 2-3 times a month for the same chest pain, neck pain, arm, back, and can't breathe, all these different things. And no matter what type of test I ran,
They can't find something.
there's nothing. And so we're constantly running tests. We're constantly looking for what's wrong. And I'll never downplay the fact that they're not feeling the pain, because they really are. They're experiencing those pains.
Right.
But what's behind that? So and now you as the therapist, as the clinician, as the the expert or the treating individual, it's your responsibility to try to help identify what's prompting those somatic feelings and what's at that, and more or less try to treat that as opposed to the pain. And hopefully if we could get at that, then we got something different. So take one, pass it around. I'm assuming we're not going to shift rooms, all right? So I think we're just going to focus on our case study, and that's fine.
How long is we're gonna be here?
Yeah.
How long is it?
Oh, the entire program is over at 9. You got one?
Yes.
Okay. So let's see what we got here. For discussion. So all those
Somatizing.
y'all can say that. Somatization disorder was a new diagnostic criteria in the DSM-3. The 19th century case is a classic example of this disorder. There's a history of many physical symptoms and complaints not adequately explained by a physical disorder or injury. They go back to the patient's adolescence. So maybe something in the client's history, some kind of trauma, some kind of something that is going on with the individual that's causing them to feel these pains. The DSM-4, which we do know we're now in the DSM-5, right? So the DSM-4 criteria for the disorder require unexplained symptoms in 4 areas: pain, gastrointestinal, that would be in your belly, sexual reproductive system, a pseudo-neurological issue. There are many references to multiple big pains and gastrointestinal symptoms. This particular client had many pseudo-neurological conversion symptoms: loss of voice, seizures, trouble walking, muscle weakness, or trouble waking. There's reference to disturbances of her menstruation. As is, you leave the case. Genuine physical problems can exist, but are hardly adequate to explain the myriad of physical complaints. The sleeping attacks represents periods of dissociation that is temporarily altered the consciousness, and it's not due to a substance or general medical condition, although in this case there are better thought as pseudo-neurological symptoms of y'all know the word. Uh-huh. Thus, the additional diagnosis of a dissociative disorder not otherwise specified is made. So, I guess as we're looking at this, if you're taking the DSM-4, not the DSM-4, but the DSM-5, let's look at the DSM-5. If we're looking at the DSM-5 and we're trying to diagnose this client, how would we look at this client? How would we rate her according to what she should be diagnosed with? And bringing it all together, pretty much somatization disorder. And it looks as if, because we didn't talk through the other half, and that's okay, dissociative disorder, right? If I had my book in front of me, if you had your book, anybody ever walk through the DSM-5 and use that to help you with diagnosing?
A little tiny, like
little
a pocket
tiny bit.
book.
Okay. Yeah.
I have it downloaded.
You have it downloaded. So have you ever walked through your DSM-5 and you understand like there are some differential disorders, different disorders that can look alike, they can kind of mimic each other, they can kind of sound alike. So it's really specific that you pay attention to the criteria, what's going on.
How are you?
Good. Hi. Come in. Tyrus, how are you? Hi. Okay, so it's really important that you pay attention to the criteria. How many.
Excuse me.
Okay. Welcome. Thank you. Looking all scrumptious and yummy over there, bringing in a plate of food, grabbing my attention.
She told me to get food.
Oh, we ate. That looks yummy. Enjoy. So talk about the criteria. It's really important to kind of pay attention to see what's going on. You want to line your symptoms up to what the criteria suggest in that DSM. You want to check it off. If they meet a certain number of criteria, then it fits the description. But you also want to pay attention to cultural aspects. You want to pay attention to differential diagnoses, meaning what it could also look like or what it could also mimic. Because aside from somatization, what's the other one?
Talking about like something like NOS?
No, I think it starts with a C.
Oh.
I want to say it's conversion disorder. You would think of that, right? Could also look like it,
Makes sense.
right? And you'll find that a lot. So what happens, there's almost always two different diagnoses that are so similar. And what distinguish that, right? What distinguish one from the other? That criteria is so important, right? So we need to pay attention to this. So I wanted to kind of go a little bit further, right? Taking this, right? Taking this young lady with all these different symptoms. I'm just put a little twist on it because I wanted to talk a little bit about how do you handle a person that's dealing with multiple issues, right? Don't quite know how to handle it, right? The pain is so much, the situations are so much, the issues are so much that they're just done. How do you deal with that? She comes to you, I can't take it anymore. It's just too much. It's one thing after the other, and nobody can seem to find what's wrong with me. I know I'm sick. Do y'all hear that? Do you ever hear that? It's there. I'm not crazy. It's not in my mind.
Well, one thing I would think to do first is to identify a trauma. Go to her history. Go back to her history and just see if there's a trauma, had to be, that provoked these semantic disorders. I believe that, like you said, that they are real, but I think she has to face whatever that trauma.
Face
Identify
what, Miss
it.
Pat? I mean, I've been doing this forever. Face what? I'm done. I'm tired.
Maybe ask her if she's ever experienced something that was, big event or somebody else close to her?
A big event. Miss Pat just asked me that. What are you? I'm tired.
I would I would start out by teaching her how to in this space sit with that for a minute, because she's been trying to figure this out for a very long time. I'm not gonna try to in this moment, like the initial moment. I'm not gonna try to figure you out. I'm not gonna throw a label on you right now. I know it's been a lot.
That's good.
Mm-hmm.
Why is that good? That's yummy. See, it was that plate, honey. Yummy.
This cake,
That was yummy.
trying to get this cake.
All right. Why? What's
She's
significant about
She's
that?
acknowledging her experience.
She's not.
The
She's not what she's
now.
feeling.
And before you can do anything
with her,
That's counseling 101.
Yeah.
You cannot leave counseling 101, right?
Mm-hmm.
Validate and acknowledge and just be there with her in that space. And I love how you said, I'm just gonna let her stay here. Okay, so now I'm I'm tired. I'm tired. Right? Let me be in. What do you mean? My skin is crawling. My stomach is constantly burning. I can't eat. I can't use the bathroom. This is not living.
It's not. And so I wonder, how much have you just felt like you're jumping out of your skin every day?
All the time.
All the time. And all of the stuff that you're taking in on a regular basis, you just can't move it through. You can't digest it. You're getting stuck up and constipated with the stuff of life.
I just want to go. I just want to leave.
Mm-hmm.
Yeah.
I'm done.
Mm-hmm.
I'm done. I'm done. I'm done.
There's two different schools of thought with that, because I worked inpatient for a long time and I actually met her per se. And like you say, when she first comes in, that's the approach.
For a little bit.
Absolutely.
Not for long.
But on her 10th admission, you don't have that approach no more.
Okay.
Because now if you came with that approach, you would be feeding the madness. So now it's your 10th time there, and I'm still compassionate, but I'm not as lenient.
So what are we doing? She's in crisis mode right now.
She's in
crisis mode now.
She's saying she's in crisis mode doesn't make her in crisis
Whoa.
mode.
I'm going to challenge that.
Okay.
All right.
Is she in crisis?
Does she have a plan?
So we can assess that.
All right.
Right?
So now what
a
do we
safety
do?
plan.
Because here it is, guys. Ladies, gentlemen. All right. The one thing that we can never do in a situation like this is call their bluff. Ever. She's screaming, I'm done. I can't do this anymore. So you keep hearing her scream that.
So what do you mean?
All right.
You're thinking about hurting yourself.
So now we move
You have
into
a plan.
suicide assessment. We begin to check the risk factors, right? Which are what? What do we know about some of the risk factors?
Does she have a plan?
Does she have a plan?
Weapon? She have access to a weapon?
Access to a weapon.
drugs?
She don't, but there's a window. My client 2-3 nights ago called 3-4 nights ago. There's a window in my bedroom. I'm like, oh mercy. This is 11:30
Cords
at
being
night.
around, different cords around there.
Cords, yes.
Past the 10th.
So now there's no
Self-harm.
what's the word I'm looking for? Firearms or weapons in that sense, but we have the cords, we have the windows, we have glass, we have all those different things. What else can we do to try to step in with that? So you getting these folks in there every day. You get at least one a day, right? Quite possibly. Yeah. What do we do?